Good morning, everyone, and welcome to another of Access California's quarterly trainings. My name is Claire Courtright. I am the Advocacy Director at Cal Voices, and I'm over the Access program. Access is a program of Cal Voices funded by our Commission on Behavioral Health. They just recently changed their name. It used to be the Mental Health Services Oversight and Accountability Commission. So any policy positions that we take are the opinion of and position of Cal Voices and not the OAC or the Commission on Behavioral Health. The topic for today is we're essentially doing a do-over of a conference that we had a couple of weeks ago relating to behavioral health transformation, as it's called in California, which is the name for the raft of initiatives from the administration around behavioral health. So that encompasses a lot of things. As part of that conference, we tried to add value to the conversation by explaining how the different pieces of behavioral health transformation fit together, because they were built to align. And we felt that was one of the sort of gaps in the way that the state has put out educational information for the community, is that we talk about pieces of this behavioral health transformation oftentimes in isolation and not how they relate. And so this training is really more about how those pieces relate, especially around funding. And so what I'm going to do is I'm going to go through, like, I won't do it verbatim as I did at the conference, but I'm just going to go through that material, which only really takes about half an hour. That's not so much focused on details, but it's focused on the big picture and how these pieces of these policies relate to each other. And then something that we didn't have the opportunity to do at the conference, because we had a lot of people in the room. I think we had like 250 people in the room. So it was not possible in that format to really take questions from people, because some of this may be new information, because it's more focused on the relationship between pieces of these policies. And I know folks did have questions, but the format of so many people in the room and panelists, just it wasn't a format that was well set up to take questions, or we would have been there all day. So again, the purpose of this is to sort of fill that gap and do an online instead of in person review of these things and take as many questions as y'all have, to the extent that I can answer them. So I'm going to blah, blah, blah for about half an hour, but then I will take any questions that you. Oh, and actually, let's pause for a moment. I guess Jocelyn just launched our poll. We just keep track of kind of who attends these things and where they're from. So if you wouldn't mind filling in your demographic information for us to know who we're reaching, that would be helpful. So for folks that just joined, we're pausing for a moment to complete a demographic poll, and then we'll jump into the content. Okay, it seems like most people have getting there, just about answered. So I'm going to go ahead and get started with the content. So again, this is kind of a refresher for what we just talked about at our annual conference, and I will take questions after this brief sort of overview. So the first thing that we did at the conference, and I think is necessary, is before we talk about all these states' policies, is just to reground ourselves in the needs of the community and why that should be a framing for how we think about behavioral health policy. And so this definitely be a refresher for anyone who lives a serious disability. Um, so obviously state the obvious, we have a whole bunch of needs, some that we kind of share with all other people and some that are mental health disability specific. And all our needs are not identical. We're the most diverse community imaginable because serious mental illness just doesn't miss anybody of any kind. And so it's, every race, class, creed, nationality, just right across the board. And then even within our community are really, really significant differences. And one that we just often don't talk about, or you don't hear policymakers center as part of the conversation, is the fact that our, first course of action, our treatment, so to speak, for serious mental illness, which is medications, don't work. We have large numbers of folks for whom that modality of treatment is not effective to put their mental illness into a place of remission or meet all of their needs. And so that is one of the really big and stark differences in our community, is folks for whom medications essentially hold some benefit or significant benefit, and folks for whom they don't. That, psychiatry refers to as persons with treatment-resistant mental illness, which is a fancy way of saying the drugs don't work. And even beyond, treatment modalities or that way of thinking, we have needs that are embedded in recovery, which is about a lot more than not having symptoms. It's about how you're going to be in the world and set your own course, for life, liberty, and the pursuit of happiness, with a disability as a barrier potentially to specific things that you want. And so, just like our needs are far beyond the treatment mentality of reduce or eliminate mental health symptoms, the way that this community talks about our needs is outside of the treatment box, right? We're talking about recovery-oriented services and supports. You do not see the word treatment there because it's inadequate to describe the need or meet the need. And we talk about the need to have competent and culturally competent services and supports, the quote unquote non-traditional stuff like peers, relationships of equality amongst us, folks who experience serious mental illness. And also, self-determination, the need to chart our own course and be allowed to have needs and have those needs met as described by us, rather than other folks sort of saying, what the problem might be. So that's just the basic grounding. And, another basic grounding is what has been the historical governmental response to people with mental health disabilities or that specific set of needs. And so we kind of know, the community sort of know what that has been. For 100 years, right after the state became a state, it was the state hospital system. It's funded by the state of California. These were public institutions, large institutions. Some of them still exist and have been in continuous operation. And then, after about 100 years of that, came the era of what we call deinstitutionalization. And that's when governments started to say, we should provide treatment located in the community, or treatment. Whoops, I just accidentally skipped my slide. And so what that looked like in California was a number of initiatives, the Short Doyle system, which was a county state cost sharing system to provide mental health treatment in a location other than inside of a state hospital. We also got Medicaid in 1965, I believe, which was also a cost sharing basis to provide health insurance to poor people and the disabled. So we were included in that. People with mental health disabilities were included in Medicaid. But from the very beginning, Medicaid did a really important thing, which said, look, we'll pay for half of covered services in your state. So in California, we call it Medi-Cal. So the federal government says, we'll pay for half of those costs. The state will pay for half of the costs of providing this mental health treatment. But there is one thing we will not pay for. We will not pay for institutionalization. So the federal government has a thing called an Institute for Mental Disease or Institutions for Mental Disease. And what they mean by that is any kind of inpatient facility, a live-in place that is larger than 16 beds, primarily engaged in the care and treatment of people with serious mental illness. Whether the door is locked or unlocked on that facility, that is considered an institution to the federal government. And the federal government has said we will not pay for any services for a Medicaid member, a Medi-Cal member in an institution. That's there for a reason. It was there to discourage the states from institutionalizing people with serious mental illness with these new federal dollars for treatment. That's just a hugely important thing. It's a major issue in federal politics and state politics right now. It's called that IMD exclusion. The other thing that we got in deinstitutionalization was our LPS Act, Lanterman-Petra Short Act, and that said that before a person could be placed, institutionalized, unlocked or locked, institutionalized for long-term, which in California means over like 77 days, you had to first be conserved under state law. So conservatorships are the front door to the institution. The short-term institution, getting institutionalized without first being conserved was limited to psychiatric holds. So psychiatric holds are institutionalization. And those large psychiatric hospitals are institutions. But there's kind of a problem, and we were talking about this a lot at the conference, which is that deinstitutionalization, the process of getting people out of state hospitals was, and into what we were calling community-based treatment was done without people with serious mental illness. It was designed without them. And so what it ended up meaning is that the few functions that people got, the few treatments that people got inside the locked doors of a state hospital were just redistributed into unlocked buildings in the community. And there was no real thought about or reflection about what do people need as described by them. So you ended up with very bare bones sort of idea of what a public mental health system or a community-based mental health system would look like. And you just saw the state hospital sort of unbundled. So, in one building you would live, apart from the building in which you would see a psychiatrist or a psychologist or get medications or learn a life skill or a job skill. So, this community has a lingo for that as a mentality and as a reality, and we call it the medical model of mental health treatment. So even that, community-based medical model system used to be a lot better funded than it is today. The funding even for that sort of medical model stuff has dwindled. Almost as soon as it was sort of well-funded, it started getting defunded. And that's the sort of a history that brings us up to the Mental Health Services Act in 2004, which I call the second wave of deinstitutionalization because it was, for the first time, a pot of money to do something different than the medical model. It was bottom up, so it was to be designed by and for the end user, people with serious mental illness. It was meant to go beyond Medi-Cal, beyond what health insurance thinks you need or is willing to fund beyond traditional ideas of mental health treatment. It was meant to fund those recovery-oriented services, upstream and preventative services, innovation. We still need to invent the things that people need in the full diversity of our community. And it provided a dedicated source of money to house people specifically with serious mental illness, which was different. Lots of housing programs in California include people with serious mental illness, but they're not sources of funding or programs specifically designed for us. And then, the modern era really starts with kind of the Newsom administration and behavioral health transformation when he became governor in 2019 or 2020. So again, a little more grounding history, and then I promise I will tell you something more interesting. What do we have today? If you have a serious mental illness, what happens? If you can't work, what happens? Unfortunately, we all know. There's not really a social safety net. It's hard to get, but you can get potentially Social Security supplemental income or SSDI. You can get supplemental nutrition assistance, food stamps. Housing at the federal level is really Section 8. I like those waiting lists are 1,000 years long. And then you can get, if you are poor and disabled, you can get Medicaid, or called Medi-Cal in California. And I will just point out one thing, which is that supplemental in the name of these federal programs is there for a reason. It's meant to indicate that these are anti-poverty programs that were not supposed to be enough money to support a person's whole need. It's not supposed to be enough income to really replace the income you need to live. It's not really supposed to be enough money to meet all of your food needs. And so this is more or less it for an entitlement program, for a social safety net for people with serious mental illness. And California does not supplement these supplemental federal entitlement programs, anti-poverty programs. We just don't have that in California. There's nothing that says if you have a serious mental illness and SSI, SSDI is not enough income to support you, then you have a right, an entitlement in California law to some more income funded by the state of California so that you can have your full income needs met. We don't have anything like that. They're called entitlement programs. We have programs that may throw some money at the problem, but they are not entitlement programs, and that's an important distinction. You don't have a right, right? You don't have a right. And so, looking at, for the entitlement programs that we do have, one of which is Medi-Cal. If you're on specialty mental health, there's a specialized Medi-Cal plan in California for serious mental illness. Like, what is it that you are entitled to in terms of mental health treatment? This is sort of the generalized and brief description of it, which again, you see, just doesn't cover a lot, right? And even what we're supposed to have, we don't have in many counties. In many counties, elements of this menu don't even exist. And so then, so what else do we have? Again, taking stock of today, we have the Mental Health Services Act, which is that outside of the medical model, outside of the mental health treatment box, special stuff that includes, our wellness and recovery centers, our peer respites, our drop-ins, peer support, the community planning process. And this money came with very important restrictions. You couldn't use any of it for any type of law enforcement purpose. You couldn't use this money for programs that were designed for involuntary participation. So like if you wanted to have a program that was just for people who were like court ordered to be in day rehabilitation under assisted outpatient treatment, could you fund that program with MHSA? You could not. And long-term institutionalization was also prohibited with these funds, meaning what? Meaning, you can't place someone under a conservatorship to live in an 80-bed mental health rehabilitation center for the rest of their lives and use these dollars to pay for it. The housing dollars in the MHSA were for permanent supportive housing, different thing. But again, the MHSA is not an entitlement program, and what that functionally means is that it's funded to a certain extent by tax dollars. Let's say there's $100 million. everybody get in line. I hope there's enough to go around. It's not an entitlement. You get it if you get it. You don't get to sue the government for it if you get denied it. So, okay, that's the stage, right? That's the stage that has been set. And that stage is that we don't have an entitlement program for housing for people with serious mental illness. We may not even physically have the houses. We have a fairly bare bones insurance system that will fund certain things that are not enough to meet people's needs. And then we have the MHSA to float on top of those insurance systems and supplement to a degree the lack of an entitlement program in California. And so then just looking, so all of these problems and the underfunding in the system are like, it's coming to a head. It's coming out now. And behavioral health transformation deepens some of those problems and kind of say why. So we know the motivation, I don't think anyone disagrees, is that the focus of behavioral health transformation is really the unhoused population that has serious mental illness or substance use disorders. There's great debate about how much of the unhoused population that just keeps growing actually falls into those categories, or more specifically fall into the categories of, you know, folks with serious mental illness and substance use disorder who also don't want treatment or housing or aren't interested in engaging in any kind of supportive service. And, you know, right when Newsom took office, really due to the pandemic, homelessness started exploding in California. And there was kind of a narrative right from the beginning that, and this is across the country, it's not just here in California. There's a narrative that says, oh, look what happened. We closed the state hospitals and all those people ended up homeless. Whoops, let's reverse that. And so you started to see that as a narrative, right? Like there's not enough conservatorships for enough reasons. The conservatorship is the front door to the institution. So we don't have enough people who are eligible to be institutionalized, short-term or long-term. And we don't have housing. And we don't have the appropriate settings for folks who have those treatment-resistant illnesses. So you started to see a lot of laws passed along those lines, right? So we saw expansions of outpatient civil court-ordered systems like assisted outpatient treatment. But there was no funding, right? There was no funding when these laws are being passed for the housing or the treatment services into which people would be court ordered. So we were expanding the net of people who are going to be ordered to engage, but we were not expanding the funding in the system to meet that demand. And that is a fundamental problem that really set the stage for everything that's happened. And so you see it, you know, repeatedly. I mean, we made big investments in clinical infrastructure, in building hospitals, MHRCs, clinical inpatient, outpatient infrastructure, but not so much in the services or housing, really. And so here we go. You know, we got longer short-term institutionalization called psychiatric holds. Those create hospital costs for the counties, IMD costs that the state has to 100% pay for, no federal participation, no federal government paying for half of it. So that increase in short-term institutionalization did not come with the funding to pay for the hospitals. We got the CARE Act that could order people into housing, apparently clinical treatment facilities, and to engage in services, but there was no money in that bill for the housing or the services. Then we got Senate Bill 43 that created short-term institutionalization and conservatorships for people with substance use disorders and no mental illness. So we got an increase there, which increases hospital stays, costs to the counties to house conservatees because they become legally responsible to do that. and there's no funding. Also, something that is just really affecting our systems right now is in the middle of all this. We also got what's called CalAIM payment reform, which is basically the state cut reimbursements to providers. That's causing real problems. We also got the overhaul of the MHSA, Prop 1, the Behavioral Health Services Act portion of Prop 1, SB 326, which said we're going to open up this source of funding that previously was restricted to people with serious mental illness or co-occurring substance use disorders to fund treatment services and housings for people with moderate to severe substance use disorders and no mental illness. But that expansion of the eligibility to have a BHSA dollar spent on you did not come with more dollars. They did not raise the tax that feeds that pool of money. So we got a sort of unfunded expansion into SUD. Then we got more, Prop 1 was a lot more money for hospitals. And then we also got in December, so just a couple months ago, we got the approval from the federal government for the state to expand Medi-Cal in a way that makes the counties and not the state pay for the half share of service. Because again, Medicaid is 50% paid by the federal government, 50% by the state of California. But we have these waivers called BH Connect that structure it differently so that Medi-Cal is expanding, but the party that has to pay the 50% share is the counties and not the state. So we call that the non-federal share of costs. So that too is creating pressures, unfunded pressures down to the county level. Also, we got a bill that allows all of our unlocked voluntary clinical infrastructure in every county to be converted to locked. It's another thing that's in the mix. We also saw expanding, in addition to care court and AOT and psych holds and conservatorships, we're also seeing a real expansion on the criminal side. So like one of the things that is happening is like last year, there was a bill, SB 1400. And what it did was say, previously, if you had somebody who had a misdemeanor criminal charge, they had a serious mental illness, they were incompetent to stand trial due to the severity of their mental illness, and maybe even non-restorable, like medications aren't going to get this person to a point where they're competent to stand trial. Previously, a judge could just drop the charge, right? It's like, misdemeanor trespassing. I can just drop that charge. They can no longer drop that charge. Now that person has to go into the CARE Act or AOT or BLPS Conserve. And you're kind of seeing the same thing with Prop 36, which was a ballot initiative that passed in November, so very recently too. And that created what's called a treatment mandated felony. So if you have a certain number of convictions for like retail theft and substance use disorder was involved, on the third strike, essentially, you have the option of going to state prison, or you can accept court-ordered substance use disorder treatment. That is also unfunded, so that's a major issue in the state right now. But you're seeing, so it's not just, you're seeing the expansion of care court, AOT, LPS stuff, but also pathways into those programs through the criminal justice system. I'm going to skip this slide. So, the point being, if we go back and reset and say, what is behavioral health transformation? It's a large number of fundamental changes to our state laws and policies for mental illness and substance use disorders in order to reduce unsheltered homelessness for those with SMI and SUD, get more money from the federal government to reduce unsheltered homelessness by expanding Medi-Cal services, and also they got a hospital waiver that I'll talk about. And it was also really the changes to the MHSA in Prop 1 were meant to and do align with the unfunded components of behavioral health transformation. So BHSA is funding the parts of these initiatives that didn't have funding. So again, we already talked about what those major components of behavioral health transformation are: the expanding court system, civil and criminal. We're building a ton of clinical treatment facilities under the Behavioral Health Continuum Infrastructure Grant Program, BCHIP, including a bunch of IMDs, so non-reimbursable mental health and substance use treatment facilities, non-reimbursable from the federal government. We're expanding Medi-Cal to bring in more federal dollars. I'll say a little bit more about how that works, and changing the MHSA to the BHSA so that it could be used to fund behavioral health transformation, including trying to bring in more federal dollars. And again, just like now, this should hopefully just be review and repetition, like CARE Act, AOT, LPS conservatorships, involuntary holds. They are intended to bring people into services who are not engaging into services. Those are all county-based services. They're partially county-funded services. And we're bringing a lot of people into a system that was already stretched really thin. This creates cost pressures on the counties. Conservatorships in particular are very expensive for counties. It is the county that conserves you. It is the public guardian for your county. And when you are conserved, your county becomes responsible for providing for your food, clothing, and shelter. The housing component of that obviously is extremely expensive. So increasing conservatorships increases county costs and pressures on the system. Those court systems create a large new demand by bringing people in through an involuntary metric. They also create IMD costs. They create hospital costs. Same thing with the criminal justice system, right? If we're bringing people into engagement in SUD or mental health services through court-ordered mechanisms, somebody's got to pay for it. No such thing as a free lunch and no such thing as a free jail. So, again, why does BCHIP create county costs? It's those IMDs, it's those hospitals that are very expensive on a per day basis, and that the federal government traditionally will not pay for half of through your health insurance. Even the permanent supportive housing can create county pressures because that housing is supposed to come with a guarantee of services, but engagement is voluntary, fully voluntary, not tied to your ability to continue to live in a place. But those service commitments create county pressures. And the reason why these expansions of Medi-Cal services create county pressures is because it was structured as a county opt-in, meaning the counties have to pay the half share of cost on these services rather than the state. So how does the BHSA fund all of this behavioral health transformation? Well, I will say this is still a work in progress. We've asked them to not do this, and I think they're going to do it anyways. But how BHSA funds all of these expanding civil and criminal court system pathways is really because the rules in the Mental Health Services Act that prevented dollars from being used for that purpose are gone. At least they're gone now. The state rewrote what's called the regulations. You look at them, you're like, is there a prohibition in the BHSA against these dollars being used for any law enforcement purpose, like a treatment mandated felony in Prop 36, a diversion program? Nope, not seeing it. And so, now these funds are potentially available, legally available to fund these unfunded initiatives like Care Court or Prop 36. The Mental Health Services Act could not be used to place a conservatee to live long-term in a state hospital or a unlocked MHRC. I'm seeing a reversal of that. In the housing intervention rules that are the final regulations that just got published a week or two ago, you can pay for long-term institutional care, including on an involuntary basis with these funds. So that flipped MHSA on its head. MHSA could only be used for voluntary participation programs. BHSA not only funds programs through an involuntary metric like Care Court, right? So MHSA dollars, BHSA dollars are now going to pay for the treatment and services that are being court ordered through care court. And actually, the way that it's legally structured, those involuntary participants in the care court program are prioritized over voluntary participants for this limited pool of funding and services. And obviously, one of the big changes from MHSA to BHSA was simply the inclusion of, the allowance for people with only a substance use disorder and no mental illness to be funded with these funds. So that, again, that opens the door to paying for the expanding civil and criminal court systems related to SUD only with these funds. Housing has a very different meaning from MHSA to BHSA. I won't go into it totally, but I will also observe that half of the housing dollars in the BHSA have to be used for the chronically unhoused with a focus on encampments. So that's the same population of people that are, the most intended for care court or AOT or LPS conservatorships, but also Prop 36 and expanding criminalization of homelessness too. And last, and I really want to spend more time on this than I did during the conference because this is extremely important. A county can opt in or out of these new Medi-Cal coverages services in their health plans in specialty mental health and drug Medi-Cal. It's called the BH Connect waiver. But if a county opts in, the obligation to pay for the 50% share of cost on those insurance benefits is going to transfer from the state to the counties. And the counties can or must use BHSA dollars to pay for that half share of costs on these new services. So all of that is to only say one thing. The MHSA funded stuff outside of Medi-Cal. It funded things Medi-Cal will not cover. It funds, I'll give you an example from Sacramento County. Sacramento County's MHSA plan funds a summer camp respite program for adoptive families of children with serious mental illness. So adoptive families have some respite and can send their adoptive children to a summer camp that people seem to love. Zero way Medi-Cal will pay for that. Medicaid will not pay for that. That is not something health insurance pays for. That is something funded purely through the MHSA. And when these dollars are being dedicated to Medi-Cal billable things and the more traditional end of the system, it crowds out and prevents funding for the non-traditional stuff. And that's
okay.
Really
how are you?
Can people mute? Again, the crossover between BHSA dollars and all the hospitals being built is a little more tenuous. It's less of an implication there. I'll talk about it later. I'm gonna skip this slide too. So I'm gonna kind of stop there, but use one graphic and start taking questions. But I'm gonna use one graphic I have in here somewhere. This drives my general counsel crazy that I'll click through slides like this. This is the best slide to explain what's going on. On the left is the MHSA, on the right is the BHSA. That purple at the top under BHSA, those are the dollars that are dedicated now to housing and cannot be used to pay for services. That's a big change from MHSA. The middle yellow portion, full service partnerships, you can see is fairly comparable to the same thing, CSS, FSP on the left. That pool of funding is relatively the same. Where you see the really big changes is in the bottom of the stack, literally, on the BHSA side, where you had a pool of funding that used to be about 38%, and it's down to 17%. It's actually 16% if you take out some of the other things the state did. So that pool of money is where the cuts are concentrated in MHSA. But that pool of money is called Community Services and Supports, General System Development in the MHSA. It's called Behavioral Health Services and Supports in the BHSA. Why does anyone care? Because that is where our core outpatient, brick and mortar, consumer operated, peer run services are funded. It's also where stuff that actually is Medi-Cal, and Medi-Cal has been grifting for a while off of these dollars, is funded. Crisis residential, some of our crisis stabilization units, drop-in centers. That pool of funding is taking the biggest hit. And this is not in the regulations, it's straight up in the statute. Who really took a shellacking is that pool of money. And that is having very real impacts today. You can go read, I think it was Voice of San Diego. There was an article that was published yesterday. The behavioral health director in San Diego just quit. And it's been there about 6 years and he quit. And part of the reason that he quit is the disruption that all of this is having in systems. And one of the things that the article pointed out is that they opened, in an attempt to keep people out of ERs, keep pressures off ERs, they opened a bunch of crisis stabilization units, but they are partially funded through the MHSA, and they just stood them up, and now there's already funding problems because of where the cuts were concentrated in the when we changed from MHSA to BHSA. And again, most of this hasn't even fully taken effect, doesn't until July 1 of 2026. So if people want to know, what's really on the chopping block based on what we know right now, it's a lot of wellness and recovery centers that are peer-operated, consumer-operated services. It is peer support. It is our drop-in centers. It is specialized homelessness centers for people with serious mental illness. It's crisis stabilization. It's crisis residential. It's important, and it took the biggest shellacking. I will say also, with respect to how much non-traditional stuff are we still going to be able to fund? Basically, all of that yellow middle portion in BHSA that was full service partnerships that included previously alternative and culturally specific treatments, peer support, whatever it takes, resources, food, clothing, and shelter. All of that has basically been converted to Medi-Cal billable services, assertive community treatment, forensic assertive community treatment. Those are the new Medi-Cal services the state went and got that the counties are supposed to pay for. And then the state has mandated, at least in their draft regulations, that the counties opt in. So you're really going to see that yellow portion, that's going to be all Medi-Cal. Kind of the same thing with what's left of prevention and early intervention, which now just called BHSS early intervention. A lot of that has been paired to Medi-Cal too and spoken for. And so, yeah, this is looking very, very different from the MHSA. And now I really will stop because I am over when I said I would stop blah, blah, blahing by 15 minutes. And people can ask any question they want to ask, and I will try to answer it. Actually, I'll see what's in the chat too. Give me one more second to kind of browse through the chat, Mary Jo, and then I'll take your question. So Richard Gallo put in the chat, County of Santa Cruz is estimated to receive $6.7 million on the housing bucket piece of the BHSA funds. According to the state, these are definitions of what counties can use while the guidance and policies are currently being drafted by the state. So Richard, they did publish final rules on more detail about what these are about a week or two ago. It's module 1 of the BHSA policy manual, housing interventions. So that's where you're going to see, and things that are specifically called out there are adult residential facilities. Like, frankly, it looks to me like nursing homes, unlicensed boarding care, unlicensed room and boards, boarding care, not great. But you can form your own opinions and look at it, but there is more detail and final rules now on housing. Alan asks about while all of this is happening, how can we avoid the similar money grabs by nonprofits and so-called providers who do nothing but bury everyone in paperwork? Also a hot topic, Alan. I mean, in terms of, how much of the services that we provide people just, you can do different things, right? Like you could employ someone to drive around people who are on SSI and SSDI because they're too poor to drive themselves and own a car, or we could give people cars, right? And so I think that's what you're getting at, is like there's a very like service model oriented systems versus just giving people resources. That's like a major issue with homelessness spending in California, where it's like we're paying a provider to man a phone line to pick up the phone and tell people there's no housing, and we're calling it housing navigation. And why are we paying for that when we could have used that salary to house someone, like pay their rent? So it's very topical, and thank you for the question. Richard asks, my county, Santa Cruz, saying that full service partnerships will be done at the county level. Is this true for all other counties? I have some concerns with FSP. So full service partnerships were very broad in the MHSA. You could do all kinds of things with them. And so consequently, there's a lot of county variability. What do their FSP programs look like? Who are the providers? What services are they really doing through them? A lot of people are getting housing vouchers through FSPs. At least, I mean, that was my familiarity from San Mateo County and working with clients there. But now what FSPs mean is going to be very regimented by the state from the state level. That's going to be in their final regulations to BHSA. It will be in the BHSA policy manual in the full service partnerships section. What they published in draft is that counties would be required to provide different levels of care and step people down in the intensity of services. What is mandated, at least in their draft regulations, was assertive community treatment, forensic assertive community treatment, supported employment, street level outreach and engagement teams for SUD, and street level initiation of MAT. So what that means is, sorry, I have a sore throat. I got to drink some. Probably not that though. So what that means is we're going to have teams of people. The FSP dollars are going to pay for teams of people to go out at the street level and get people on medication assisted treatment in the community. Medication assisted treatment for SUD means opioid replacement therapies, so like Suboxone, methadone. So that is a mandated part of the FSPs. I don't think the state's going to like go back and make those regulations different from draft to final. So you will see very regimented what it means to be an FSP in every single county. And they designed it so BH Connect is the expanded Medi-Cal services for assertive community treatment, forensic assertive community treatment, and then they mandated it over here. So that's why you're going to see that yellow portion become very sucked into Medi-Cal. And again, like all of the MHSA, BHSA funded services are funding CareCorps, they're funding AOT, et cetera. So you're probably going to see a lot of that be involuntary too, or court ordered. Oh, thanks. Zoe dropped the article from Voice of San Diego in the chat. Y'all should read that, because I think if you read that after seeing this presentation, you'll be like, okay, I see what's happening here. Thomas Beam asked, why do they seem to be pushing to lock the unlocked facilities? Well, I know why, and it's to implement Senate Bill 43, because Senate Bill 43 is the one that said we can put people on psych holds and conserve them for a substance use disorder only, and also for expanded reasons for mental health. They made that a lot bigger, but they didn't have the hospital beds to put those people in. Our hospital beds are generally pretty full. And so the way to get hospital beds without building them, the way to get them really quickly is to take existing facilities like an unlocked mental health rehabilitation center that's 80 beds, throw a lock on the door and make it a psych hospital. So it is to be able to implement these laws faster. That law said it had to be implemented in every county by January 1 of 2026. You can't build a mental hospital in 2 years for the most part. So the reason why there's the ability under Senate Bill 1238 to convert all of our existing unlocked infrastructure to locked is to be able to implement that law. Thomas also asked, when do you think Module 2 will be finalized? The $60 million question. I think according to what I've heard from the counties is that they expect that policy manual to be done sometime in May, so pretty soon. And we'll see if that differs. Richard Gallo said, unlocked facilities, including nursing homes, is due to the lack of psychiatric beds and no affordable housing, including supportive housing. Right. And I mean, and that's one of the issues that nobody's really talking about is like, what kind of housing do people with the most severe and unremittent mental illness need and want, right? So do we have that? Are we even trying to make that? Someone, I'm sorry, not someone, I can say who it was. Claire asked in the chat about tiny homes and observed that the demographic of the unhoused that is growing the most quickly is seniors and seniors with disabilities. And she points out that Sacramento has a program that it built some tiny homes and is, wondering what the solution is, because yeah, it takes a long time to build to build real permanent housing. And one of the things that people have been looking at is this kind of like interim stuff that is maybe not the best, but is quickly constructible. And I know that there was a push for that for a while from the state, and then a lot of it hasn't materialized. I don't know why, but people definitely have been looking at that as, at least for now, a policy solution to try to get more housing stock. Jody said Los Angeles is building a new facility to be an in-between at BHUCC and hospital. They can stay up to 14 days with an extension of 21 days if needed. It will serve adults in one section and minors in the other. They already broke ground. Yes, Richard's talking about the community planning process. Okay, and I'm sorry I made you wait so long, Mary Jo. Do you want to ask your question?
I've got a couple. First of all, under BH Connect, with clubhouses being looked at as one of the 6 categories that are evidence-based practices. Yeah. What I know that you guys did a recommendation, a statement in response to the draft policy manual, module 2. And the whole thing with crisis stabilization units and what they were talking about, peer respite as a transition from hospitals and crisis stabilization. We just did a crisis stabilization in conjunction with a hospital. Hello, that's exactly what Steve was talking about, at the conference. But I think my major question is, we've got all of this issue with stakeholder involvement. How do you keep the counties accountable to what that stakeholder involvement causes? We've been contracted with UCSD to do the whole community engagement piece. So they're going to get all this information. They're going to do a report. This has been going on for a couple of years. And but how do you hold the county accountable to what the people are saying they want, given all the limitations and restrictions under DHSA? I know that's a long, multi-part question.
No, it's fine. We're here to do it any way you guys want to do it. So I'm, for the benefit of the larger audience, I'm going to kind of explain what you're asking. And I put up this slide that I didn't actually use at the conference, but probably should have. It's like, what is this big fight between, you know, the consumer operated services like wellness and recovery centers and the medical model and Medicaid? Like, why is this such an issue? And it's such an issue because in order to be inside the insurance model, insurance billable, you have to do a bunch of things that are, one, logistically difficult, two, expensive, and three, cause us to have to sacrifice our culture, our model of care, and our purpose. And so, you know, if you are, and I will give an example of this, right? If you are working at a pure respite that is not Medi-Cal billable, that is not as a so-called site certified, what can you do there for your clients when you're, you know, financed by cash and you're outside of the insurance system? Well, we can have a program that's completely non-clinical, right? We don't employ any psychiatrists or psychologists or LCSWs. It is people with serious mental illness in a non-traditional model, taking care of people with serious mental illness in crisis in a small residential setting that is purely voluntary. But you try to do something inside Medi-Cal and here come all the rules, right? So here's an analog. Like, I actually am a big fan of crisis residentials because I worked at one. Those are Medi-Cal billable. They're site certified, but here come all the rules. The rules are that a clinician has to run the place and therefore controls the culture. The rules are that that site has to be sober and maintained as such. So what does that mean for the people that are staying there? That means that when you come back from the store with your shopping bag, I have to search it. You know, so what happened to your Fourth Amendment rights against warrantless surveillance, right? I mean, there is the devil's in the details with this stuff. And, you know, on top of it being logistically difficult and expensive, the fight for our wellness and recovery centers, for our peer drop-ins, for our peer respites that are operating outside of the health insurance model, like, this is it. How much do we have to give up of the reasons why we're separate from the health insurance system to begin with? In order to get jammed in that box. And it's a major debate in the community. Some programs are trying to figure out how they can become Medi-Cal billable and get inside the insurance system. And some are like, we never want to do that. We never want to do that because what we have to give up is everything. So that's kind of the argument. And what Mary Jo is pointing out is that what was included in these expanded Medi-Cal services is what they are calling clubhouses, which is a very old 60-year-old model. And we don't even really know what they mean by it because those are traditionally consumer operated services, but when you jam them in the Medi-Cal box, they aren't anymore. And what they were saying about clubhouses and being billable, wellness centers are not billable. They didn't even try to make a pathway for that. But you know, when you get jammed in the Medi-Cal box, what happens? Well, they want a work order day at the clubhouses, and they want that to pair with their supported employment benefit under Medi-Cal. And then we're like, but are you going to do all of this in an involuntary model? Is a court going to order me to like get a supported employment job in this clubhouse? Like, what are we doing here? You know? So that's part of the fight, is that they included clubhouses. I believe they did that because NAMI California operates a bunch of them. But they included clubhouses. They didn't include wellness and recovery centers. And everybody is now on the knife edge of, are our programs closing, or are we going to be able to jam ourselves in the cow box and not lose our souls? And then with respect to accountability for the counties, Mary Jo, it's hard. I don't think anybody, I mean, you've been around and engaged for a heck of a lot longer than I have, and a heck of a lot longer than most people. And if you're still asking this question, and we're all asking it of ourselves, how does this community actually have a voice? I don't know, but I will say, I think it's growing again. Okay, any other questions? Let me look in the chat again.
the problem that I see with this, Claire, is that if they do this, first of all, going to the work order day is a disaster because that takes away everything that drop-in centers, the original thing, were. They're going to require us to do documentation and keep writing records that's never been done. And I'll be nice in my language. What they're doing is totally stripping the whole movement of what it has been, for over 30 years. And what I want to see and what I want to know is how do we do what the movement originally did back in the 60s when they deinstitutionalized and said, no, we're not going to be under the system, and went out and did their own stuff. And that's where I see the hope for where we're at, is being able to go outside of the systems and find our own funding to do our own thing independently. I mean, that's, in my mind, that's the answer.
There's a limited number of options. I mean, a lot of us do peer support as on a volunteer basis informally all the time. I mean, one option is you just do things because your community needs it and you sacrifice, and it's not your job, but it's your passion. I mean, like, however you feel about AA, they've always stayed out of government systems. And for the people that benefit from that, they really benefit from it. And that was a choice. So one way to go is you don't mess with funding at all. And you're all volunteers. I mean, another way to go is you get cash funding dedicated for the purpose, like the MHSA, but obviously we're not able to keep that for very long. The other option is the systems themselves internally change. So Medi-Cal starts recognizing, or health insurance starts recognizing, that what we do is fundamental and important, and they're going to fund it, and they're going to change their rules so that their rules work with our culture. Those are basically your options, I think.
But if we do it as volunteers, we can wind up homeless.
I know.
Because they don't have an income.
And many of the people that I know are the hardest working people are homeless, and they're advocates. I'm going to check the chat for questions. Richard asked, Claire, can you correct me if I'm wrong? It is my understanding that peer programs are not included with Prop 1. That's a great question, Richard. So not in the way that they were in the MHSA, right? Because in the MHSA, for instance, in community services and supports, general system development, there is just fairly unrestricted funding to fund a peer support program. There's fairly unrestricted funding to fund a wellness recovery center. All of your actual operating costs, not based on some provider reimbursement rate. There's nothing like that we're seeing in BHSA. So what has happened to peer support in BHSA? Well, they're willing to plug us into roles that they've created in organizations that are not run by people with serious mental illness. They are not consumer operated, peer operated services with their own brick and mortar location, their own culture, their own supervisory structure. It's a lot more like, people coming to us and saying, well, do peer support workers want to be supporters in care court? No. I mean, most of us know, right? We're not going to work in models where people's engagement with us is court ordered. That's just not what we do. We will never do that. And so you see, like, where is peer support included? Well, they'll shout us out. You can be a member on an FSP outreach team. But that is not a peer-run organization doing peer support. So I would say what BHSA has really done is it's made it very difficult, if not impossible, for consumer operated and peer operated services to continue to exist. And it's also kept peer support in name only, where individual peer support workers are eligible to be on teams that are run by clinicians that are serving the expanding populations of people who are court ordered. So where do we fit in? It's a good question. Was that a clear enough answer, Richard? Crystal Rain says Los Angeles VPAN Veteran Peer Advocacy Program knows it will be defunded in 2026. I'm sorry. Looking for other questions. Kathleen Derby asks, so no peer-run operated programs funded at all by BHSA. Heard peer respite may be an option. Again, it's a really good question. Kathleen, sorry, I had to get your name. It's a really good question, right? And the distinction is not so much that you can't fund peer support or they didn't plug us in as individual workers in different systems. The issue is that within Medi-Cal billability, that is not does not meet the definition of a consumer operated service. Now, some of us look at it and say like, okay, we have our brick and mortar location. We are willing to be Medi-Cal billable because we're going to go hire, you know, the person that we're going to hire officially, the clinician that needs to be in charge so that we can bill Medi-Cal, that's going to be a friendly clinician. That's going to be a clinician that shares our values. So maybe we can do it. But in terms of, you know, is there a similar sort of pool of funding in BHSA that is like MHSA Community Services and Supports General System Development? Not seeing it. We're not even called out by name anymore in the BHSA, and we had to ask to be re-included in the places where we think the funding is slushiest, you know, most broad, I would say, and most outside of Medi-Cal. But, you know, like, frankly, Kathleen, no, I don't see it. Cal Voices did some very lengthy comments on their regulations, asking them to put us back in. We'll see what happens. Those haven't been published in their final form. In terms of peer respite, some peer respites are billing Medi-Cal. I think Nevada County's is, but it's operated by the county. It's not operated by, it may be technically operated day to day by a community-based organization. It is the county's program and it is Medi-Cal billable, and that will always come with strings attached. And so, you know, and we care who runs it too. You know, I mean, the term peer includes family members, but as everyone who is aware, you know, especially like NAMI California has become pretty much exclusively a family member peer organization and not an organization that is representing the wishes of people who actually have serious mental illness. And so sometimes you may say it's a peer respite, but we're like, well, who's the peer, right? Like, is it a family peer that doesn't want to hear anything from the consumer peer movement? You know, who are these peers you speak of? So that's an issue too. Mary Jo O'Brien said, what will the impact of changes and threats from the Fed and current administration? Ooh, that is the hottest of topics right now. And I have to say, I didn't really mention part of the BH Connect waiver was a BH Connect IMD waiver, meaning what? Meaning California got $1.9 billion, limited to 5 years, to pay for the half costs on acute psychiatric hospitals, on locked IMDs. Okay. So there's more money for these hospitals coming into the system. But you're also looking at the federal government looking really hard at those types of facilities and that type of funding. There's a series right now in the San Francisco Chronicle that is horrifying about IMDs in California and what's going on. And those hospital costs are creating real pressures in our system. They're too expensive, essentially. And when they're run by hedge funds and private equity, they have really high profit margins and they're a drain on the system. And so it's like, which way are we going to go? Our Medi-Cal program had to take $6.2 billion in loans in the last week to keep making payments, loans from itself. So I don't know which way this is going to go. And this is before the federal government sort of gets in the game of cutting Medi-Cal. I will say that to the extent that I've heard Republicans, they know it's not popular to cut Medicaid at the federal level. And I have heard, that at least some people are saying, look, we understand that people with disabilities need this health insurance and that we should not cut it. I don't know what's going to happen, but the federal government set a goal. Some members of Congress set a goal. So not necessarily Trump, and not necessarily Bobby Kennedy at HHS, but set a goal to cut $880 billion out of Medicaid over 10 years. I think it's like 1 year is $880 billion. You're talking about very, very significant cuts to Medicaid. Have no idea how those will be structured or what those look like. Have no idea really what the politics is on that, if that's doable at the federal level or just kind of aspirational on the part of Republicans. Don't know, but definitely know that if you read that Voice of San Diego article that Zoe shared in the chat, that's one of the things being discussed is like, look, things are not in a great shape financially for our public behavioral health systems now due to the cuts from Prop 1 and CalAIM payment reform, and we're staring down the barrel of whatever the heck the federal government is going to do. Yeah, it's not a great time. Kathleen asks, what about MHSA values? Peer and family centered, culturally competent. Great question, Kathleen. Those are the general standards to MHSA. Where they live in the law is called the regulations. And that is a part of the law that was delegated in Prop 1 to the Department of Healthcare Services to wholly rewrite, and they are. And I haven't seen those values in the regulations that are coming out from DHCS. So I don't think that's there anymore. Oh, Alan, you're going to suck me into the real page rabbit hole. I want to get sucked into that rabbit hole, but I have to do that as it's slightly off topic with you privately, but real page is a problem. Gregory Fearon said the BHSA 3-year integrated plan requires behavioral health BHBs to include all available funding, including local sources, which may be able to begin to support more peer-based programming. That's a really great point, Gregory. And yeah, I don't know about those other funding sources. So what's part of what's new in Prop 1 is that these plans that the county is going to make for BHSA funds includes now, right? There's this big plan that the counties have to make for SUD, for mental illness, all sources of revenue coming to the county, including their own local resources, are supposed to be coordinated and planned for and spent under this integrated 3-year plan that includes the BHSA dollars. And so does that mean that potentially there are other funding sources that we've never talked about in the peer community that could be coming in and make up for some of what is being taken away in the MHSA? That's a terrific question. I kind of asked the state, like, do you guys have a laundry list? There is actually a laundry list to an extent of the other funding sources that exist. But when they exist at various counties will have like measure whatever ballot initiative they pass. That's a special tax that may fund behavioral health programs in their county. I don't have that level of knowledge down to the county level, but shout out to you for bringing that up, because people trying to save their programs and they're involved in the community planning process for BHSA should be looking around and going, is there any other pot of money we can use? So thank you so much for raising that. Oh, shout out to Mary Jo. San Diego pilot program of $500 shallow subsidies, which go directly to the landlord for seniors, has kept me housed. We need more of these. Focus needs to be on homeless prevention. Yeah, that's a really great point, Mary Jo. And I will say you're not the only person to have ever said that. I think that's very much the position of the University of California, San Francisco, Benioff homeless and housing initiative is like small subsidies keep people housed. Small direct subsidies keep people housed. I know that's one of the policy proposals out there. Let me see if I got other questions. Say, Mary Jo, I haven't watched any of the committee hearings in the legislature about what's going on with Medi-Cal funding. I don't think the governor was specific on what's causing the cost overruns when they asked for that $6.2 billion loan in the last week. I just don't know. Some
No,
people
but
say
there
it's
was,
this. So I don't know, and I don't want to comment on it without knowing, because I know press has asked the Newsom administration outright, like, why are there cost overruns? Identify for us where they're coming from. I don't think that's happened yet, so I don't really want to speculate on where they're coming from.
there was testimony I saw in the budget committee from Michelle Bass, looking at that. I was looking at AB 96 yesterday, and there's also another bill by Eggman, SB 369 or 367, that's doing more with conservatorships. Robert had mentioned something about it. I don't know if that's something you've already covered, but anyway.
Maybe
There
she
was,
wrote it, but my understanding is she was term limited out of the legislature in the last term. So maybe she's writing bills for people, but she's no longer a sitting
oh,
legislative.
maybe it's the old bill then. Okay, I got it.
Okay.
Okay.
And I'm going to take Alan's question.
Okay, just a second. I had to hit unmute. Hey, thanks. Really, just a question or comment is people have I mentioned the real page thing, but I was trying to lay the groundwork for trying to point people to look out for attempts to sneak in, and they may still end up getting there, or reinforce credit reporting of rental history into these various bills. The first words that I've seen is where they will allow it, which is opening the door for it. There's a massive company out there called Built that's trying to use the window that's being opened in the antitrust discussions between Visa and MasterCard to create a new something new that's going to track where we live and how much we pay, and report it to everybody, all our future employers, future landlords, et cetera, et cetera. So they're doing so on a point-based system. So if you participate, if you live in if you're a young person, participate in one of these nice new buildings, you can get free yoga classes if you sign up. So thanks.
Okay, Alan, we'll nerd out on this because I have a lot to say about that. And I very briefly yelled at my board of supervisors about banning RealPage in Sacramento because it affects me. But so for those, I mean, it's like very much an aside, but RealPage is a algorithmic rent price fixing software that it's a company that's being sued by the United States Department of Justice, and a bunch of large landlords are being sued by the United States Department of Justice because it's price fixing of rents. And it's like, its economic impact in the country is probably like way massive and people aren't really talking about it, but it's definitely affected certain communities that were targeted, especially San Diego.
Real quick, so what they do is they keep artificial shadow inventory out there, which affects for all of the, if you think about it, for all the subsidies we're giving in order to try to quote unquote make rent more affordable, all they're doing is backing into what they need to extract more from us through our taxes, and then charging us for that by monitoring exactly and controlling how much everybody pays everywhere. If you ever lived in Irvine, California, you know exactly what they're doing.
Yeah, I found out about them in a completely innocent way. And I was like, oh boy. Yeah, no, I know that's well, I'm rabbit holing. So if there's no more questions about the MHSA or BHSA, or kind of what's going on in the policy space, then I think we can call it. I'm just making one last run through for hands. Okay, I don't see any.
I don't have any questions, and I've been real quiet. I've been right all along.
You always are, Robert.
There, I think there is one more in the chat from Kathleen. She mentioned something about DHCS.
Oh, can you ask the question? Oh, Kathleen, is there a public comment period for the portion of BHSA that went to DHCS? In particular, I would like the opportunity to comment on former MHSA values. Terrific question, Kathleen. So technically, so they set comment periods. They gave almost no notice. They were less than a month on very lengthy and complicated regulations. Those comment periods have closed. But if you read their very first final policy, well, the first module of the BHSA policy manual, so the first set of final regulations, the very first thing they say is we can change these at any time in an informal manner, and we probably will. So that being the case, Joss, would you look up really quick the behavioral health transformation website and drop it in the chat? There is an email address, Kathleen, that you can still send emails to. I believe it's BHT policy feedback at like DHCS or something, but don't quote me on it. If Jocelyn can pull up the DHCS behavioral health transformation website and drop it in the chat, you can follow that link, Kathleen, and the email address is somewhere on there. And if you can't find it, just reach out because I have it, because that's where we were submitting comments to. Oh, and I think Thomas has his hand up.
Yeah, Claire, is there a chance that you can just briefly touch on, because for me, it seems like most of this has been kind of negative in regards to wellness centers and peer support specialists in that area.
Yeah.
So is there any hope in like AB 96?
Oh, so that's a great question. So Cal Voices is sponsoring a bill, AB 96. It will let, if it passes, it will let folks who have a Medi-Cal certified peer support specialist credential be a recognized form of a community health worker, which is a Medi-Cal provider type that can bill in more places in the insurance system than Medi-Cal certified peer support specialists can. And related to that is the ability for peer-run orgs to maybe be providers of services for that professional type. So for CHWs like enhanced cares managers in CalAIM, we're going to try to do some content around that, Thomas. You're right that AB 96 is one of the attempts to continue to have vehicles within the insurance system for peer-run orgs to provide peer support services, either under their own MCPSS or carved out preventative services under CHW label. Yeah, we're trying. I mean, I think there's lots of irons in the fire in terms of, one, trying to get an explicit call out of peer operated, consumer operated services in the BHSA regulations. We want to know where's our pot of money and how unrestricted is it? And we want to see our names there so we know. And we can plan accordingly. So that's one effort. You know, another effort is, you know, we also said, look, if you're going to put clubhouses in as an expanded Medi-Cal service, put wellness centers in and let us figure out how to exist in Medi-Cal. We're trying a bunch of different things, but one of them, you're right, is the CHW route, the managed care route. It's a lot for this conversation. We will do some content specifically around it, but yeah, I mean, there's a lot of efforts to try to save this infrastructure, and we don't know for sure what's going to happen because it's very difficult even for the counties to figure out where their money's at because of all the changes that are happening. And so I think the counties, I know you came to the conference and we asked a couple of the counties, like, how you doing? You know, like, how's the
Right.
money looking? Like, do you have money? Do you not have money? And they're like, we definitely don't have more money. We,
Yeah.
none of these initiatives gave us more money. We're not coming out net ahead. But, we do want to save these programs. We do value peer support. That is a priority. And if you ask them, like, I think the response from one county is like, look, because of the other related initiatives like CalAIM payment reform, one week I have $10 million, the next week I'm in the hole. I don't know how much money I have. I don't know to what extent that's going to get figured out as we head into the community planning process, which should start sometime around May if they get those final regulations and spending rules out the door. But it's really kind of like up in the air. And I don't know if people are not being forthcoming about it because it's bad and they don't want to just tell the community, look, the ship has sailed. There's nothing we can do. We're facing really steep cuts. Or if there are vehicles because of how complicated all the money has become, I don't know. But I will say again, if people want sort of like a preview of what's going on, it is in that Voice of San Diego article. And also in some articles in the Marin Independent Journal about their programs, and all the counties are facing this right now. There is a lot of uncertainty, and I cannot say for sure which way it's going to go.
We'll read that article when we get done here, but I have a follow-up question. What do you think the chances are that the recommendations you made, on the public comment, will be incorporated into that finalized module 2?
Fairly good.
Okay.
I think that when we've raised this very directly and said, okay, you've shuffled around all this funding, you've changed the law, the statute, you've changed the regulations, where do we fit? Where are our names and where is the priority for us? They've been like, don't worry, you're not there anymore. You're there, but it's been very non-committal, and we did very specifically say, I'm sorry, can other people mute? We did very specifically say, here's where you can legally put us back in. Here's where you should prioritize the preservation of consumer operated services, brick and mortar services over funding anything else. And we'll see. I don't know.
Right. Okay. Thank you.
Mhm. Claire asked, can Cal Voices please help explain the various positions, Republican and Democrat for governor? That's a really great question. I have not followed their policy positions yet. And people are still announcing whether they're going to run or not. I know Katie Porter recently said she's going to run for governor. I don't even know who's in the race. Rob Bonta is not. Rob Bonta decided not to run, and I don't know what their positions are right now. Okay. Robert, you got a question?
I'm sorry about that. Why my copy is making so much noise. I just wanted to touch upon something that Mary Jo had mentioned in regards to the Senate bill that's being amended, and it is actually a psychiatric bill, Senate Bill 367, and it's also in the Voice of San Diego, and it's just like my prior predictions that conservatorship is the plan for California to cure homelessness. So the mayors, San Diego's mayors won. You will see basically San Diego Mayor Todd Gloria and other city representatives are lobbying for a change to care court to include stronger links to conservatorship.
Yeah, I saw that. I actually, you're making me realize I did go look at that bill very quickly. It's a spot bill right now, which means
Yeah.
they put in some language as a placeholder and they haven't told you what the bill really says yet. And sometimes they don't tell you until we're supposed to be done and over. So
Right.
yeah, there's that one. There's also a bill from Senator Stern to expand care court to people with bipolar 1 disorder. Don't come for me. And there's also there's another Umberg bill about care court, and there's Umberg bills about Prop 36 and mental health or SUD diversion, that I think are going in the same direction.
So I don't know. I want you guys to be prepared. It's coming.
Yeah. I mean, but the thing is they're broke, so I don't know.
Yeah. Well, they were broke when they did the 3-strike law and they found money to lock people up.
I feel you. Okay. I don't see any more hands or any more chats. Every time I think I'm done, though, I miss somebody. So let me just scan one more time. Check the chat. Gregory?
Yeah, I just wanted to ask, I'm new to this. Where are you going to post the video of this so that I can send it to all my behavioral health board members?
Sure. We post them on our Cal Voices YouTube channel. So if you just go on YouTube and search for Cal Voices, that's where they're all posted for Access California.
Thanks a lot.
Okay. All righty. Well, thank you so much. Thank you for the discussion. Thank you for the questions. I really enjoy doing that with peers, as opposed to the more formal stuff like a conference where everybody's in a suit. Thanks for your time. Thanks for all the work that you do. We will post this, and I'll cut the slide deck so it's appropriate to what we actually went over in the meeting today. And that will be in the description of the YouTube video. And I think that'll be it. Thanks so much. See you next time.